Hello, my name is Marc Ryan, the Chief Strategy and Compliance Officer for MedHOK, and welcome to one of our podcasts. Today's topic is exchange plans in the coming rigorous compliance environment. We've talked some time ago about the emerging healthcare landscape, and we talked about the fact that there seems to be a fairly vigorous endorsement by both Democrats and Republicans now in having a private healthcare system, one that might be regulated by government, but the delivery system is in the hands of private health plans. This conclusion was made largely because all politicians and regulators at the federal and state level determined that the traditional fee-for-service environments are just too inefficient, and it's very difficult to guarantee quality in those kind of transactional systems of care. So they have endorsed managed care delivered by private health plans as the best way in America to begin the process of offering cost-effective and quality health care. Therefore, the levels of insured is increasing in these private health plans for a number of reasons. Number one, the Affordable Care Act, or PACA, expanded Medicaid in many states. About half have elected to do this. And that has led to an increase of millions in the Medicaid programs throughout the nation. They also created the state and federal exchanges, which has also added millions more to health care as well. In general, Medicaid states are expanding managed care and private managed care plans because, again, they see that as a better way of delivering Medicaid. There are the dual demonstration projects, which are the joint partnerships between the federal and state governments. And lastly, notwithstanding some predictions that Medicare Advantage growth was going to stymie because of a major financial realignment, Medicare Advantage is growing very robustly. Today, about 1/3 of all Medicare beneficiaries are in Medicare Advantage plans, and in highly competitive large urban areas, Medicare Advantage enrollment actually outstrips the traditional fee-for-service enrollment in those counties or areas. While tens of millions or more are coming into health plans, and private health plans have to be really happy about that, at the same time, state and federal regulators are enforcing a much more accountable infrastructure on the clinical quality and the compliance front. And what we've said before, and we'll say again here, is that we at MedHOK see all lines of business converging on what we're calling a national healthcare accountability model. Medicare Advantage has really been leading the way on this front for the past several years. Now Medicaid states are being forced by CMS to improve on performance and outcomes, and so we're starting to see that change and come to Medicaid as well. And lastly, although the exchanges are brand new, we're already beginning to see a compliance infrastructure emerge by the day, which will mean that in a short period of time, perhaps just in a couple of years, the compliance infrastructure for state and federal exchanges will mirror the Medicare Advantage program. To give you a little more details about this exchange regulatory regime that is already emerging, again, the first year of the exchange was all about correcting the failed launch in October 2013. If we go back in time a bit, we know that that was a major issue related to the website working and the actual enrollment process with health plans. And now the federal and state exchanges have sort of weathered that storm. Things seem to be corrected. They recovered in terms of enrollment into early 2014. And the enrollment season in late 2014 leading into 2015 for the second year of enrollment actually went reasonably well. While absolute numbers are not being met yet, there is a lot of traction being built in terms of exchange enrollment, and predictions about a death spiral in terms of rates because of adverse selection, although there are remaining concerns, do not seem to have happened. Because of that, the federal government is already looking toward a long-term plan to roll out a very strict regulatory regime for the exchanges. And this will mean a series of things. One, very strong regulation and compliance mandates. They're already seeing enhanced audits and things of that nature that are already occurring, and that will mean sanctions probably in the next couple of years coming out. And I do think we're also going to see pay for quality in a very short time because they're already moving in that direction. Traditional commercial-only plans are really in for the greatest shock here because if we think about the commercial world, it has really been the least heavily regulated of all three lines of business. Traditionally, state insurance departments were the lead regulatory agency, and these state insurance departments really pretty much focused on solvency. While there were network and other mandates, it was really meant to ensure that there was a regulatory regime that said the health plan is financially solvent, there are some member benefit protections, and they're delivering care, but they really didn't go much beyond that. And again, quality and other factors, if they were looked at, they were often very weak. That's not perhaps the case in every state in the union, but that's probably nationally, generally the way it worked. Now we're starting to see CMS, the Centers for Medicare and Medicaid Services, become the lead entity in overall regulation of exchange plans, but also for non-grandfathered plans that aren't even in the exchange. And that will be the predominance of commercial coverage, whether it's group or individual markets moving forward. And CMS is really looking at all aspects of a healthcare plan when it comes to this exchange regulation and in part non-grandfather regulation. There's an annual bid process in the exchange that provides a vital insight for CMS to really see what's going on with the plans. Formularies have to be filed. Networks have to be declared and looked at by CMS. Financial bids and benefits are all submitted as well. And CMS is already beginning to use that roadmap and the best practices that they put into the regulatory regime for Medicare Advantage as a blueprint for the exchange oversight. What regulation is already in place? Well, number one, under the exchange regulations, there are mandatory turnaround times and authorization and appeals. Essentially, the exchange world uses the ERISA DOL mandates in these areas. There's also an establishment of external review under the Affordable Care Act, so any denials made by plans are under increased scrutiny by independent review entities hired by the federal government or by health plans to review plan decisions on appeals. Already there's a fairly rigorous formulary management in the exchanges, including broad drug inclusion and, more importantly, mandating exception requirements. So if a drug is not on a formulary, there has to be a process in place where a member can come in, ask for coverage of that non-covered drug, and the plan has to consider it and grant it if it's medically necessary. There's increasing scrutiny of network adequacy that's already occurring in year 2, and I expect that that will increase over time again. And this year, for 2015, there's now a rollout of requirements for quality improvement programs. And while these are in its infancy now, this likely will result in much greater clinical care management mandates that are very much unfamiliar to payers outside the Medicare and to some degree the Medicaid market. I really believe the largest focus is going to be on quality outcomes moving forward. It's important to note that already CMS has established a sort of beta program for 2015 for CMS exchange and state exchange quality. There are 19 core clinical and 10 survey measures that are tied to HEDIS and Pharmacy Quality Alliance measures. These combine adult and child measures. The measures are focused on disease states, wellness, prevention, behavioral health, readmissions. So they're very broad measures capturing individuals from birth all the way up to right before Medicare kicks in. Next year, there will be an additional 12 core clinical measures that will be added, along with 2 additional survey measures. So by next year, you will have a suite of clinical and survey measures that are as robust as you see in the Medicare program, with the complication that you need to excel both on adults and child measures to be rated well. By 2017, the program will really be in full force, including publication of quality scores on the plan comparison website for the exchanges in time for 2017 enrollment. So members will now be able to tell what are those highly rated plans and what are those plans that are lagging. As we know from Medicare Advantage, publication of such measures begin to have an impact on member behavior. For example, in the Medicare Advantage world, just in the last couple of years, the number of plans that were rated 4 and 5 star has increased from 20% to 40%, but the number of people in Medicare Advantage plans that had 4 or 5 stars has increased from 20% to 60%. So it's a good indication that member behavior does respond to these publication of the scores, and that will probably impact member choice over time. While price may be a very important indicator, I do think that quality and the so-called star rating in 2017 will begin to factor into enrollment in plans because of member decision to move more toward a quality plan when it's publicized. And again, it's important to note that this beta test and the rollout through 2017 for the Exchange Quality Program mirrors very much, again, the Medicare Advantage ratings program. It has HEDIS and PQA measures like in Medicare. It has CAHPS and HOS type of survey measures that are going to be included. I believe it's only a matter of time before CMS brings in pay for quality as it has with Medicare Advantage. In this case, perhaps somewhere beyond 2015, you will begin to see CMS having bonus payments like they do in Medicare Advantage to truly reward those plans with high quality performance with more revenue that would be shared in terms of benefits with members. As we've said with MA, it will be nearly impossible very shortly for an MA plan in the Medicare world with less than 4 stars to compete. Again, not too many years from now, it's a distinct possibility that same will likely be said of exchange plans. CMS believes strongly in tying risk adjustment and quality payments. We're seeing that emerge all over the place. And again, in the Medicare Advantage world, having a risk adjustment system and a quality bonus system seems to work well. We already know that the exchange world has risk adjustment. So again, it's not much of a leap to think that a pay for performance quality payment is coming up next. Why does CMS like that? Because it recognizes high performers. It also recognizes those plans with greater adversity with those risk adjustment payment. And lastly, it really fits in well with the highly competitive bid process where plans race to the bottom to attract membership, and then they ultimately succeed with quality bonus payments and a fair risk adjustment payment, recognizing any adverse selection that might occur in their plan compared to others. Thanks again for joining our podcast. Before we conclude, I just wanted to talk a little bit about MedHOK. As you know, MedHOK is the only single platform for care, quality, and compliance. You can see a number of our modules here. If you're interested in learning more about MedHOK, you can visit us at www.medhok.com. Thanks again. Take care.